Shar and Dr. Joseph Kvedar.
Sit over here. Good afternoon, everyone. Thank you. I'm Al Shar. I'm really very pleased to introduce and share the stage with Joe Kvedar, who is the founder and director of the Center for Connected Health at Partners Healthcare. He's a dermatologist at Mass General and a faculty member at the Harvard Medical School. As if that weren't enough, in his spare time, Joe is one of the founders of Healthrageous and a board observer there, and a mentor at Blueprint Health. Joe, in talking about patient engagement, Jay Sanders recently, he's sometimes referred to as the father of telemedicine. He recently said that we're going about healthcare quality improvement all wrong in focusing on physicians, and that the real change we need is to affect the consumer. What's the Center for Connected Health doing about engaging consumer and affecting their own health status?
Well, thanks, Alan, and thanks to the organizers for inviting me to be part of this. I feel as if I've come home because we've been working on patient engagement for some time. For us, that really is very simple. It simply means keeping you focused on something of mutual interest. In this case, it's improving your health. We take a lot of our cues, however, and we try to learn from all of the amazing work that's been done in the online shopping world, where each one of us now, if you go on, and I'm guessing everyone here does, to buy something on the internet, you get a completely different browser experience than your neighbor. And it's because each time you go, computers in the background are collecting your digital breadcrumbs and feeding them back to you as compelling content to get you to change your behavior, to push the buy button. So we have this experiment in mind that we think we can do that, except we want you to get the push the get healthier button. And that's a journey that we're on. We have really worked in chronic illness for over 10 years now in this, and using feedback loops, that is collecting data that's objective about your illness, and then allowing, in the current iteration, healthcare professionals, nurses, pharmacists, other professionals, to engage with you around those feedback loops to keep you improving your health. And we've shown that that works in several chronic illnesses in a remarkable way: heart failure, diabetes, hypertension, all really exciting, solid outcomes, proven by scientific studies, and then taken into programs and now being adopted at Partners. So it's really our fundamental wish that the patient drives this. I don't think that's just trendy. I think that's how we have to push healthcare forward in this day and age, because we don't have enough providers to go around. We all need to be our own doctor a little bit.
Yeah, it sounds a bit like you're talking about a piece of the sort of quantified self movement, where people who have their own Fitbit, they're taking measurements, they're comparing themselves against themselves, and in an attempt to both understand what their bodies are saying, how healthy they are, and whether or not they can get healthier. It seems to me, though, that that's a very small percentage of the population. And maybe the chronically ill behave somewhat differently. and certainly those people that think they're healthy, who probably can benefit from understanding what their bodies are saying to themselves, look like another population. How do you work with those?
No, that's a fascinating analysis. So the quantified self has done a lot to raise awareness of the power of tracking. And tracking is very powerful. If any of you have had the experience of driving down typically a rural road, you see a little sign with a speed limit posted, and above it this flashing light with the speed you're really going. Most of the time we slow down when we see those, and I don't know if you've ever stopped to ponder why. there's no policeman around the corner, you just slow down. That's the power of the feedback loop. And indeed, as you said, Al, we estimate somewhere between 5 and 10% of the population are motivated enough, quantitative enough, keyed in enough to take those feedback loops and improve their health. And they need really very little else. Actually, in our experiments, they end up being the control group, because every time we run a clinical trial, the control group is usually the feedback loop alone. And then there's some intervention on top of that. It could be a coaching intervention, it could be a social networking intervention, could be an incentive program, a walking challenge, a competition. We use all kinds of these things to study them. And we found reproducibly that another 50 or so % of people will resonate with that particular intervention, whatever it may be. And then there's another 40 or 30% of people who check out completely, and they're always the people that you don't see on the graph because we're comparing the control group with the intervention. Another phenomenon we see is that intervention line tends to stay flat for the duration of the trial. And where we are now with it is we're really trying to understand each and every individual in any given intervention, because of all those motivators that I mentioned, social networking, incentives, games, coaching, we all react to a meld of those at a given time, and then it changes over time. And if we can learn enough about you and your current state to keep changing that messaging over time, what we hope to see is two things. One is more and more of the population will stay engaged, so we don't have that cutoff at about 60%. And as we run the trial, we'll get more of an uptick as opposed to a flat response. And we're seeing that right now. We're doing an experiment with diabetics, mashing up location data, motivational data, and activity data into an algorithm and churning out twice a day personalized, customized, motivational text messages. And that's what we're seeing. Patients' activity is going up over the trial. We're engaging more and more people as the trial goes on. So it's the beginning of a long journey, but it's an exciting one.
Yeah, it sounds, especially with people like diabetics. I remember, maybe 2 or 3 years ago, a number of studies came out with text messaging. And they were all trials that were maybe 6 weeks long. And they showed a 6-week change. But I can guarantee you that if they sent the same text message after a year, no one's going to pay attention to it.
No.
You've got to be looking at those things.
Yes, so that's the idea of customization and changing up the messaging. And of course, not everyone will resonate with text. We know that. It's the way I look at this challenge, and it's the research agenda of our group for the next 5 to 10 years, actually. Because we can maybe come back to this, but we can add genetic data in as well as an input. So it's the inputs, geolocation data, genetic data, mobile purchasing data, connected health data, motivational data, etc. And then the outputs are ways to engage you that particularly resonate with you at that point in history, where you are with your healthcare journey. And that's what we want to build in again, a highly customized way. And I'll say it one more time, but the only reason I stand or sit here in front of you and say that we can do that is because it's already been done in online shopping. It's a solved problem there. We just need to change it into health and solve it in that way.
Are you looking also at those people who are have a baseline healthy, and in terms of helping improve their health status?
So not as much. I think the two ways that population comes in are the genetic risks. So we're just really starting that part where the power of getting your genetic risk, particularly at a young age, and then crafting really a lifelong engagement program around avoiding those things that you're at risk for. Some really powerful things you can think of. I don't know if anyone here who is not diabetic tracks their glucose. I doubt it. Anyone stick your finger twice a day if you're not a diabetic? It sounds absurd, but there's a paper a year and a half ago from a fellow who's the chair of genetics at Stanford, published in a very prestigious journal, Cell, about his journey. He had his genome sequenced. He learned that he was at risk for type 2 diabetes, and he started tracking his glucose, which for the first year or so stayed in the sub 100 fasting range, and then, by God, it bumped. And he watched himself develop type 2 diabetes. And then, using some other connected health interventions, dietary tracking, activity tracking, put it in remission. And that's an amazing story. That's the power of genetics and the phenotypic mapping we get with connected health. So there's really a lot we can do with that. We're just at the beginning of that.
Yeah, it's intuitively clear, at least, that establishing unique methods of interventions can be much more effective than something across the board. But it's also clear that without some kind of technology, that you've got an impossible task in front of you. What's Connected Health working on in terms of dealing with that space?
Well, so there probably are some population level things that we could say will work a majority of the time. Their social networks are very powerful. Most of us resonate with social messaging in some way, whether it be through, and I think the variability isn't so much in the social, but is it social in terms of a competition? Is it social in terms of making sure your buddy, there's certain people who, they want to help others so much that they'll pay attention to the other person being healthy. There's certain people who just want to beat you in a competition. So social is very powerful, and I think almost all of the interventions we're talking about can be enhanced with a social component, as long as we understand the variability of how people will use that to be successful. Incentives are similar. I think almost everyone will respond to an incentive. Short term, I think, long term, it's hard to match. If you give me a big pile of money to do something for the next 3 months, what's your encore going to be? And that's, I think, a challenge. But again, as a population level tool, probably sure. And then there's the part where we start to collect all those digital breadcrumbs that you're leaving behind every day. How many text messages did you send, and can we mine those? Privacy, we'll pay attention to privacy. This can all be done with machines in a way that's de-identified. Can we mine those messages for health-related information, or even the frequency of them? People that are depressed will send fewer emails and texts, and start to develop a profile for you, a motivational profile based on how you interact with your environment through typically your mobile device these days, but maybe a computer as well.
Well, you just mentioned the word privacy that I want to come back to. Because it's one thing to sort of broadly say de-identified, but what you're doing is you're capturing a lot of information about an individual, their health status, where they are, what they're doing, what they're buying. And you need those data to be able to wind up responding and incenting appropriately. But you also need to wind up protecting that data in a way that doesn't allow others to take advantage of that.
Sure.
So let me push you a little bit and what are you doing to try and keep that curtain there?
Well, I do have your profile, and if anyone wants to buy Al's profile, no, just kidding.
And I'm scared.
Listen, the profile, the privacy issue is so important. We take it so very seriously. I think it's a solvable problem, and in the following ways. And I look at it as a series of trade-offs that we will individually make. We live in the United States of America, which is a libertarian culture. Therefore, if you don't want to share your data, you'll never have to. It's that simple. There might be consequences to that. Your health insurer may charge you a higher premium if you decide not to share your data. That is possible. I could see that future, and I think it's, because let's face it, if you wall yourself off and decide that you don't want to share, someone's going to have to pay when you get sick. And shouldn't you pay a higher percentage of that? That's, again, I know controversial, but I can see that potential. And then the other is, again, the trade-off of having every one of us be healthier, live longer, happier, versus the trade-off of a potential data breach. And data breaches will happen. I wish I could say they never would. They happen today. We will do everything in our power to keep the data that we have locked up in 10 different ways, as should everyone else, and there will be regulations and laws and all of that. I think that the power of using these data to improve the health of individuals far outweighs the risk of a data breach. That's just my opinion on it.
I think we have to be, and we clearly don't have the time to discuss all of the issues associated with privacy. Privacy is, to my way of thinking, especially when we talks about health and healthcare, an extremely complex set of issues, and it's not a single issue.
No.
It's not even a set of issue, not even a single issue for an individual. You know, depending on who I am, where I am, what I'm feeling, my tolerance for a breach of privacy is vastly different. If I'm in an emergency room and I need critical care at that point of time, I don't really care.
That's right.
If you find out things about me. I'd love to be able to repair it afterward, but this is a very, very complex issue, and I think that too often we really trivialize what we mean. But I
couldn't agree
I think
more.
we both agreed that it was something that needs to wind up being mentioned, and you know, an understanding that most people that are working in this space do understand that it's complex.
But it will always be an opt-in. It's never going to be an opt-out. I can't imagine it in this country being an opt-out. It's going to be an opt-in anyway. So that at least should put some of your fears at rest. The data breach fear, it's complicated, but again, I think the societal trade-offs outweigh the risk.
Yeah. Okay, as we move forward, it's certain that some of the tools that you're trying are going to work, and some are not going to wind up working. Some may work for a period of time and need to be changed as they become more effective. It seems to me, how do you study this? How do you actually wind up knowing? The medical model for testing these things is to try and fix everything, keep the intervention the same over the longest period of time possible, and then declare victory. What we're talking about is a very different model.
Well, we only work on things that work, so that's easy. We wouldn't be an innovative group if we didn't have a high failure rate. I think a couple things about that, and buried in that, and Al and I know each other for a long time, is our collective interest in studying these things in a different way than the sort of standard randomized controlled trial, which, although a source of truth, is also laden with restrictions that make it challenging. And I often say to people, because we do both at our center, we run programs and we evaluate them in real world, and we do clinical trials. And many, many times what we've learned in a clinical trial, we put that into practice in the real world, and we relearn everything we learned because it's different. So a couple of new things that are exciting on that front, I would say one is our ability to pull large data sets from our electronic record as comparators. That shortens the time to do an evaluation. So you take a field project, evaluate it in the field, and then you can go and pull usually a 3 or 4 or 5 times as many people with the same condition from the electronic record. There's quite a lot of lengthy cleansing of those data that goes on, but once you have that, you have a nice comparison. We just did this, for instance, with heart failure telemonitoring, and showed a remarkable change in mortality and readmissions in a very, very elegant way that did not have to involve randomizing and controlling, which is liberating. So, and I think others can do that, and of course, this whole effort to bring all these medical data to the fore, we'll have a lot of data to mine in that way. And the other is just rapid iterative change, which we do a lot of. The engineering methodology, try something a little bit, or today's, I think, lean startup pivot, whatever you want to call it, but we do a lot of that quick turnaround kind of innovation, throw something out there, and your just gut tells you, you got to fix X or Y, and you fix it. And when we get it so that more people than not are benefiting and liking it and giving us positive feedback, then we'll go and do the trial that's a little more scientific.
Okay. Joe, you and I have been doing this for a long time, and there's not that much time left, but we know that healthcare is both difficult and very hard to change. What needs to happen for connected health to become the norm?
Well, so, yeah, succinctly, I would say the following. If we look at it from a physician adoption perspective, and I say that, I know it's an engagement conference, it's about patient empowerment. Patients have never stood in the way of this. They've always wanted more, just like those AT&T commercials that are out there now. So patients are not the problem. Physicians are more reticent, and at least for certain kinds of constructs around caring for illness, we do need to involve clinicians still. They tend to adopt on 3 levels. One is quality, and I think we've passed that bar with Connected Health. What I mean by that is we don't need to do too many more studies that show that heart failure telemonitoring is as good as coming to the office, or doing a virtual visit is as good as seeing someone in person. Most of that work's been done, and it's been done a lot, and you can wave your bar charts and your p-values now, and most doctors will not shoot you down. That's our experience. And then a second one, which is really important, is how do I get paid for it? And the change in reimbursement from volume-based to value-based, which is happening at least in Massachusetts and some other states, and I think will sweep the country, that's fundamentally making it like a new day for Connected Health, because I don't have to measure myself by traffic through the office anymore. I can think about population-level care. And then the third one is workflow, and that's all the good work that people are doing to integrate some of these tools into electronic health records and into patient portals. And we've done that at our shop. All of our Connected Health data now can be viewed in the electronic record. Patients can see it in the portal. That's part of the feedback loop I was talking about. And that's helped us move forward much faster, particularly for programs that are based in primary care practices. So I think it's those 3 things. That's a very provider-centric view, but as I said, we don't need to spend a lot of time on consumer and patient adoption because they just eat it up.
You want to mention one thing about one of your most recent successes in terms of, again, you mentioned heart failure.
So one of the things that we pride ourselves on at the center is we try to think 5 to 7 years ahead of where our parent company is and what's going to be of value to them. And we do this thing called programs. I alluded to that, which is different than a trial. It's putting something out in the real world and preparing it for scale. And we've just now completed the journey with heart failure telemonitoring, which we started 10 years ago. And as of this fall, the Center for Connected Health will not be in the middle of that operation at all. We'll be innovating the next generation of those tools, but the actual heart failure telemonitoring, which will be standard of care for high-risk heart failure patients throughout the system, will be run through Partners Health at Home, our home care organization, and funded by the Population Health Management Group, not funded as a research project. So that's a nice example of a handoff, and we're very happy about that.
I think victory is when the innovations are no longer branded as yours,
That's
but
right.
become owned by the populations.
Yeah.
We have
A couple minutes for
a
questions.
few minutes for questions, if anybody. It's hard for us to see up here, so make sure someone's...
Thank you. Kenyon Crowley with the Center for Health Information Decision Systems at the University of Maryland.
Hi.
Great work. The question I have is, so for the different personality attributes that are moderating the effect of interventions for different populations, in your experience and judgment, What do you think are those most important attributes of patients that are influencing how effective different interventions are?
Well, I think two things come to mind. One is there's a great power in them feeling tethered in and cared for. So, of course, even if a healthcare provider isn't talking to them at the moment, the very nature of a connected health intervention is that someone will be there when they need it. When it works really well, someone is there before they need it. So the heart failure patients will say they love it because before they get short of breath, the nurse is on the phone asking them why their weight went up. So it's that's one, the cared for. The other is people who respond to authoritative coaching do really well, i.e., and those of you in the audience who aren't this way know you're not this way, but if you care what your doctor thinks about you or your doctor's agent, i.e. a nurse in the practice, you will do well on these programs because that's the way they're set up, is a nurse is watching those data as they come in. They're objective data, you can't argue with them, and they call you out. If your sugars are 300 3 days in a row at 6 p.m., you'll get a phone call. Let's have a chat about what's going on. So it's that sentinel effect and the flip side of it, which is the feeling cared for. I think those are two important ones.
Hi, my name's Betsy Weaver, and I'm the CEO and president of UbiCare, also from Boston. We worked on we were one of the companies on your innovative
Indeed. Good
last
to see
year.
you.
I have a question. You said a moment ago that all of these things will always be opt-in. And we work with hospitals across the country, and in more hospitals, and I would say this started with a chief at Boston Medical Center who said, wait a minute, why is it that I'm asking for a specific permission to give a patient information and resources and things that I think they need to have, and I'd rather have them have ours than go flying around the web. So in a sense, he said, I don't think this is an opt-in. I think this is, in fact, part of my care, and I have an obligation to do that. That's one example. Another example at New England Baptist, they are doing an experiment, and they said, we are going to require all of the people in this experiment to be getting the same weekly email messaging services from UbiCare because we think they need to have that as a baseline. What do you think about that, Joan? What do you think about the opt-in versus this is a part of care?
So those are great stories, and thank you so much for bringing that up. And it allows me to clarify what I was talking about, which was really the privacy part. In all of those scenarios, best I can tell, it's an outward bound messaging scenario, and of course the opt-out there is someone decides to delete or not pay attention, right? They mentally opt out. But what I was talking about is programs where we're passively collecting data about you and using those data to uniquely message you about your health. I can't envision a time when, for instance, whatever's on your mobile phone about you today, that I'll be able to get that without your permission. I doubt that will be the case.
Hi. Good afternoon. My name is Steve Davis. I'm a psychiatrist. I work for a company called M3 Information, and we have a patient engagement tool for people with mental health disorders. I'd like to hear some of your experience with engaging folks with mental health or substance abuse problems, particularly in light of the fact that when undiagnosed and untreated, people with chronic comorbid medical conditions, those conditions tend to be much more expensive to treat. They're not as well managed by the patient or by the providers, and then they suffer more complications. And when you do a good job of identifying and treating, you can save a lot of money. Looking at some of the data from several different states, the cost can be as much as double in those patients. So I'd like to hear some of what you guys are doing in that area. Thank you.
Well, I think you're far ahead in your thinking. I couldn't agree with you more. We have noticed that in our populations of chronically ill, particularly diabetics and heart failure. And it's just harder to engage those folks. And so, again, when your engagement tool is a nurse calling someone on the phone, you have the ability to customize based on that individual's instincts. And we do that. But as we move into this land of automated care and automated messaging, we're going to have to be smart enough to pick up some of those cues from, again, your passive data collection to be able to start to have better sense about how to message you and get you out of that funk, get you into the right care plan. It's an enormous problem, and you've articulated it nicely, and if you're doing effective work in that area, you're doing God's work, because it really needs to get done.
Yep. Mental health, especially addictions, can be extremely complex.
Very difficult.
And complicating. And even being able to communicate an inkling that there's something more than the underlying disease that you're trying to treat going on, that there's a comorbidity associated with something that has social stigma attached to it, is very, very complex. There are things that are being done, but they're subtle. They start dealing with issues that come back to issues of privacy, issues of how do you move in a careful way to be able to address those kinds of things. I see we're out of time, and I personally want to thank both Joe and the audience.
Really wonderful.
It's been really great. Thank you.